I'm Sarah.
I'm Tara.
I'm Babylonia.
I'm Tyler.
And this is our presentation. So our case study involves Colleen Smith. She's 26 years old. She's a female who is unmarried. She's a secretary. She's being admitted into the hospital for having lower left quadrant pain. She has a history of watery bowel movements containing bright red blood occurring every 2 to 3 hours for 30 hours. She has a 4-year history of inflammatory bowel disease, or IBD. She has been hospitalized once for it at the time of her diagnosis. She's not taking any medications, but she does take Metamucil as needed. She lives alone and is in the process of moving from one apartment into a house. She has a boyfriend. Her boyfriend informed the emergency department nurse that she is worried about her finances. She has no income if she is out of work. Her insurance only covers 70% of hospital expenses and some of the doctor's bills, but it does not cover prescription medications or doctor visits. Sam is the nurse on the unit assigned to Colleen's admission assignment and developed an individualized plan of care. The emergency department nurse called the following report. Blood pressure is 100/68, pulse is 110, respiratory rate is 18, and temperature is 104. Colleen will be prescribed several medications on her discharge and will need to be out of work for 2 weeks.
Okay, so I'm going to next discuss the economic implication and issues surrounding this case. Initially, the things that stand out most are that she's financially not very stable. She works as a secretary, and she vocalized her concern to her boyfriend about being worried that she wouldn't be able to pay for the hospital bills. So just in general, in 2014, estimates of direct and indirect costs range between $14.6 and $31.6 billion for costs related to IBD. So that's a lot of money that's going straight to just this one disorder out of many. Factors that contribute to this cost are treatment, inappropriate treatment, lack of adherence to the therapeutic regimens, which could result in having to get hospitalized in the future for something that you didn't take care of initially, and then also suboptimal treatment. The issues for the patient, IBD ranks as one of the 5 most expensive GI disorders. The costs associated with that are hospitalizations, prescribed medications, over-the-counter medications, physician visits, diagnostic procedures, and missed work. And that was another issue in the case study. She was concerned that because of this, she would have to miss work and therefore not have an income. And I also found that the estimated medical expenses for insured patients is around $19,000 per year for Crohn's disease and approximately $15,000 per year for UC. And it's important to note with this, it's not just, a little expense. This is a lifetime expense. It's something that she's going to have to deal with for her entire life, and it's a costly disease, unfortunately.
All right, so managing personal health. So what we want to do is we want to educate Colleen about inflammatory bowel disease. We want to have her talk to us about her lifestyle and see if we can make any lifestyle and diet changes. A couple things she can do is drink plenty of water, reduce stress by exercising and relaxation. We can also limit dairy products, eat foods high in fiber like fruits and vegetables, and whole grains as well. So we want to teach her to avoid problem foods. So obviously drink plenty of water, avoid spicy foods, don't drink caffeine and alcohol. Complementary and alternative medications are available as well. So because she is struggling right now and worried about not being able to afford her medications, She can try things like probiotics and prebiotics, as well as fish oil. Okay, so drug management, we want to assess the patient's pain level, we want to check for allergies, we want to teach her how to take Metamucil. So she's taking Metamucil as needed right now, so the usual dosage for that would be 1 rounded teaspoon in an 8-ounce glass of water 3 times a day. So we want to make sure that she's stirring the Metamucil so that it's not going to have a congealing effect. And we want to make sure she never takes it in drying form. Drug management, there was no specific drugs indicated when she left the hospital, so this slide just gives a few examples of what she would have. She would be prescribed anti-inflammatory drugs, as well as immunosuppressants and antibiotics. And eventually, if that does not work, surgery would be recommended after lifestyle changes and diet and drug management has failed.
So there are a few implications of if she is not compliant to her drug regimen. Medication adherence can be defined as a failure by patients to do activities or follow up the treatment guideline recommendations made by the healthcare provider. And what we want to make sure that she does is follows the drug management guidelines that her healthcare provider sets out for her as much as she possibly can. Because if she doesn't do it, then she's looking at different implications like disease relapse, colorectal cancer, increased hospital admissions because there's going to be multiple flare-ups that could happen. And all of these will end up costing her more in the long run if she doesn't get it taken care of now. And then if the patient is adherent to the medication and treatment, there's an association of a reduced risk of relapse. And if she is getting the medication that she needs and she stays on it, then chances are she won't run into any of these issues it won't be as likely that she'll run into these issues.
So planning out her discharge orders and whatnot can be kind of tricky because we do want to address her needs, especially being in the financial situation that she is in. So we would want to incorporate everything that's needed to help with the disease, because if this disease is left untreated, it could lead to ulcerative colitis or even become cancerous. Colleen should consult with her doctor to talk to the doctor about her needs and her worries. That way he can address them as well. The doctor could possibly talk to the insurance company about possible exceptions. The doctor could also prescribe a generic version of the medications. That way it's a little bit cheaper for her, and that would decrease the costs. For Colleen, it would be imperative to have a schedule. That way she could organize things and have a reduced stress load, as well as incorporating exercise into her lifestyle whenever she's not having a flare-up. When she is exercising, it is a way to decrease stress as well. So in this schedule, she could write down a lot of things. This could help her manage her disease as well by finding out foods or drinks that might trigger her IBD, which would be very imperative for her.
Okay, so how does nursing relate to the Christian worldview? So when we look at the Christian worldview, we look at some key factors of that is basically loving others is a key element of the Christian worldview. And this is because our God first loved us as Christians, that we're able to see what love actually is. And we see that all throughout the Bible, how Jesus, he went and he sat with the rich, he sat with the poor, he healed the sick. Those who came to him, he paid attention to, and he paid attention to everyone the same. And one way that we show love is by doing good works for other people. And these are good works that are rooted out of loving others, and not because we want something in return for them. It's a selfless love, and which brings us into the next part. Good works are selfless, and they're for the benefit of the receiving person, and they are done regardless of race, sex, or socioeconomic status as well. And so nursing actually involves pretty much all of these as well. So in patient care and advocacy, part of being an advocate for the patient is actually realizing that that patient is a specific person that is special and and he or she is unique, and we are working for them at the center. It's patient-centered care at the center of who we are as nurses. That's what we advocate for, and we should be working selflessly and for the benefit of who they are as a person, whatever treatment that we're giving them. And this is all done regardless of what's going on with that patient, who they are or who they aren't in our eyes. And actually, many of our jobs that we do as nurses can be considered a good work that are incorporated into every single thing we do because of these reasons. And one good quote that comes to mind from the Bible, from Galatians in chapter 6, verse 2, is bear one another's burdens and thus fulfill the law of Christ. So, and one of the good works that would be considered, one of the jobs that nurses do that would be considered a good work is patient teaching. And what patient teaching does, it empowers the patient to be more aware of their situation. And thus, by educating our patient, by giving them the patient teaching they need about whatever's going on with them, their disease, or whatever is their disability, it helps them to know their situation, and in knowing their situation, they're able to make better choices in improving their overall health and managing their situation. It allows them to follow through with drug management. And this is important because them knowing why they're taking the drug, what the drug is actually doing in their disease process or their disability, plays a huge role in the fact that they will actually continue this. And then also too, it allows them to feel more in control of their situation, because with more knowledge comes more control. The more you know, the more you're able to actually take a hold of your situation and own it and actually know what you're doing. So, and one of the other reasons why this is a good work, especially in nursing, is because we do patient education regardless of their economic status. So if they're rich or if they're poor, it doesn't matter. They still get the same education. Even if we think that they won't understand because they're poor, we still educate them the best way that we can. And that could either be through visuals or through actual written communication that we write down, which steps to take or whatever it is. So their education level does not play a factor into if we should give them patient education. It plays a factor into how we should give them patient education. And this is also considered a good work because lower income patients also can ask about different options of how they can possibly get the same treatment or similar treatment for a lesser option when it comes to money if their insurance doesn't cover anything. And we can explore those options and talk with our doctor too to try to get them the help that they need. And it also emphasizes treating all income levels as equals as well. And we see this just like Jesus as well. He came for everyone. I know I previously mentioned he sat with tax collectors that were some of the most wealthiest people, and he sat with people that were poor, people that were lepers that had no control over anything that they could do, and they were at the bottom of their socioeconomic status at that time. And as nurses, this is what we're called to do. We're called to love our patients regardless of anything that is affecting them or anything that is afflicting them as well. And that concludes our presentation. These are